This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Good afternoon. I'm Sonia Malexidae, Director at Large for the Academy's Board of Directors and Chair of the Otolaryngology Program Directors Organization. I practice in Washington, D.C. at Georgetown and the VA Hospital, and I'd like to welcome you to episode 17 of the Academy's COVID-19 podcast series. In this episode, we will discuss trainee education and how it's been affected during the COVID-19 pandemic and what it might look like looking forward. All aspects of life as we know it have been affected by this pandemic, especially healthcare. And I think that this conversation is very relevant, and I'm thrilled to be joined by a great panel today, and I look forward to hearing their perspectives and thoughts on this topic. First, I'd like to introduce Dr. Stacy Gray. She's Vice Chair of Education and the Residency Program Director in the Department of Otolaryngology, Head and Neck Surgery at Harvard Medical School. She's also President-elect of the Society for University Otolaryngologists. I'm also joined by Dr. Jeffrey Simons. He's the Coordinator of Education for the Academy and Professor of Otolaryngology at the University of Pittsburgh. My next guest is Dr. Richard Smith. He's the Immediate Past Coordinator of Education for the Academy and Professor and Interim Chair in the Department of Otolaryngology at Montefiore Health System and Albert Einstein College of Medicine. And of course, last but not least, Dr. Carla Valenzuela. She's a PGY3 resident physician in the Department of Otolaryngology at Washington University in St. Louis. And she's also chair of the Academy section for residents and fellows. So thank you all for joining me today. I want to kick this off by asking each of you to maybe briefly share the COVID experience in your respective hospitals and some opening thoughts that you might have about the pandemic. And so Rich, I want to start with you. As chair of a department in the epicenter of this pandemic, in the Bronx and New York, walk us through what this looked like for you and your department, your faculty, and your residents.
Thanks, Sonia. It was truly an unexpected kind of horror movie type of moment when we realized exactly what was hitting and what we would have to do. And it was disruptive across the entirety of the institution as well as the department. It's really staggering if you think about the numbers. So for our health system, we've had more than, I think, 8,500 COVID positive patients. At one point in our core hospitals, we had almost 2,000 COVID positive patients admitted. And we were mandated by the state to do things like increase our bed volume. We tripled our ICU volume by creating new ICUs across the institution, which then, of course, needed many more people to staff them. So all of us in the department at the provider level were staffing ICUs, including the residents and the faculty, for 4 to 6 weeks. The rest of our department, all of the associates and staffs, were deployed to other areas of the hospital to serve in functions such as screening patients and providers on the way into the hospital, to being unit secretaries in newly formed medical units, to all sorts of things that would not be in their usual description. So it was really an amazing time to see what had happened, to really understand the extent of the epidemic and pandemic, for people in the department to be out of their comfort zone, experiencing new things and contributing in ways that they were possible to do, and also to see how they really rose to the occasion. It was amazing to see everybody take ownership of that, volunteer. We had volunteers in the ER before we were deployed, and then everybody volunteering and doing the things in the ICU. And we were staffing ICUs 24/7, so the shifts were 12-hour shifts, 7 to 7 a.m. and p.m. and vice versa. So people really pitched in and gave us all their best, and that was really heartwarming and amazing to see.
Yeah, no, I just watching it on the news from afar and seeing what New York City was going through, it was just, it's impressive what the city, was able to do. Are you back at some sort of semblance of normalcy?
Well, it's returning a little bit. We started reopening our office spaces last week. We've changed what we do quite a bit. We're seeing only one patient every half an hour when we do, and we're not having as many providers in the office at a time because we're concerned about social distancing, maintaining safety of both the patients and the staff, and really letting everybody know that we have their best interest. So it's coming. We have not yet been able to start surgery again. We've paused all surgery for 8 weeks unless it was an absolute emergency. We had no place to put patients. Almost the entire hospital was COVID positive at that point. So it was very difficult to do any cancer surgery. We had cancer patients who were waiting 6 to 8 weeks for their surgery. Now we've resumed that, and we're waiting for the governor's okay to resume elective surgery for other patients. So it's been a big disruption, and we're coming back to a new normal. It's not going to be what it was 3 months ago, that's for sure. We can't do that. We won't be able to practice that way. And I think that that's a lot of the conversation that we're going to be having this evening, how that interacts with resident training and education, including surgery and all the rest of that.
Stacy, you next, in being in Boston, another epicenter, if you will. Tell us a little bit about what that was like for you.
So I think compared to New York and New Jersey, I certainly think we did not experience anything near the same degree that was experienced there, especially just from talking to friends that are in that area. We had a little more time, I think, and especially watching what was happening in New York and New Jersey, I think that really helped the hospital to have us pause earlier with stopping surgical and other outpatient care. We are still, the hospital is still quite full where we are with patients, although the numbers have been steadily declining. We have not really restarted our sort of normal practices either. So we are still, there's elective surgery has still not been okayed by the governor of Massachusetts. We're still just doing only urgent sort of emergent cases. Just this week, I was able to schedule some cases that have been put off for about 8 weeks that are more sort of pre-cancer, concern for cancer cases that I'll be able to do tomorrow. But that's the first time that I've really been able to do a non-emergent case. And similarly for clinics. So we're waiting, I think probably June 8th is when the potential for sort of starting elective procedures will potentially restart, but we're still waiting to hear from the governor. I think we also have very similar experiences, though, just in watching everybody really come together to really handle this. Our hospital is a little different because we have a separate Ioneer institution. And so we're physically connected to Mass General Hospital, but we have our own emergency room that sort of is functioning independently. And so the way that we were utilized is maybe a little different than other places in the country. Right now, we actually have what's called a post-acute COVID floor that is centered at Mass Ioneer. We turned our pediatric ward into sort of this recovery unit for patients that have been hospitalized in the ICU and intubated for several weeks and are sort of medically better, but not ready to go home and not really sort of at the level that they can really go to rehab. And so we sort of opened that floor and our residents have been staffing that. So not the acuity of sort of working in an ICU setting, but it's actually been really heartening to see these patients that were so sick for such a really long time, especially with the stories that you sort of hear on the news, and they're better and they're, leaving the hospital within a few days of being there. So that's actually been, I think, really nice for us to be able to see that and participate in that way.
And Jeff and Pittsburgh, tell us about that experience.
So today in the office, I saw patients that had surgery. I saw follow-up patients that had surgery at the end of February and beginning of March. And it made me really think about how much the face of medicine has changed and the otolaryngology world has changed in the past 2 months. There were drastic changes here as well. We did not have the same volume of COVID positive patients as we're seeing in the New York, New Jersey, Connecticut area, but we were certainly hit here as well. I work at a freestanding children's hospital, and we also had children in the hospital that were COVID positive, even though it seemed to hit the pediatric world a little bit less hard than in adults. There's definitely been patients that have been in our hospital that have been COVID positive, which has made us all have to think about how we approach patients and our own safety, the staff safety, other patient safety, and certainly our trainees' safety. We had all operations that were elective shut down for 6 to 8 weeks. So our surgery centers closed, elective surgery at the main hospital closed for that period of time. And really, I've only started elective surgery again in the past 1 to 2 weeks. In the office, it was the same way. We stopped seeing all routine visits and routine problems in the office, and the office only open for emergency patients. One shift that led to, and I think it's been this way around the country, is a remarkable increase in the amount of telemedicine and telehealth that has been done here at UPMC and Children's Hospital of Pittsburgh, and I think that's been mirrored by many other places around the country. So if we look at the beginning of March, there was maybe 5 or 10 telehealth visits at Children's Hospital of Pittsburgh per day. And at this point, we peaked somewhere around 1,800 visits a day, not just for our department, but for the whole Children's Hospital doing telehealth. It's made us all learn how to do that. There are certainly challenges in otolaryngology and certainly in pediatric otolaryngology as well with what can be seen with telehealth. There are some things that are great, for example, follow-up sleep studies, follow-up imaging studies to discuss surgery. And there's some things that are not so good for telehealth. For example, examining ears and performing endoscopy of the airway and things like that. But it's made us really think about how we can, how we might be able to do things in a different way, in an innovative way, to safely take care of patients. I suspect that some of the changes that we've seen as a result of coronavirus are going to be longer lasting in medicine, and we're probably going to see the landscape and the way we practice medicine will be different for the long haul, not just over the past 2 months.
Yeah, no, great points, and we'll touch on some of those in the next hour or so. Carla, tell us about St. Louis.
So I think, we definitely weren't hit, obviously, like New York was, and I feel like we were just waiting for the surge to happen. My hospital acted very early on about just trying to keep the numbers low. Our elective cases were canceled in the middle of March. Early in March, we were having discussions about, backup plans for residency rotations, restructuring residency rotations. So overall, we never saw the surge that we expected to see. And I feel like out in the Midwest, we just kind of were preparing to see it. And luckily, we haven't seen it. And hopefully we won't see it anymore. But that's been my experience. We've just been following along with what's been happening across the country.
Yeah, the disparity of the experiences across the country, it's interesting. So I want to transition here to sort of the focus of our conversation today and how graduate medical education or residency training has been affected by this. Certainly the medical students, we know they were, very quickly pulled off service, and then they, because of PPE and their safety, were taken completely off the wards and off the hospital, and they were sent to sort of virtual education. But I'd love to hear what happened at your institutions for the residents and sort of how your department handled it. Stacy, maybe we can start with you, the program director at Harvard.
Sure. So I think very quickly, we realized, and it's interesting now because I think we've had some time to kind of think about things. So the way that I look at this is there was sort of, and something that everyone should have really well thought out, sort of an immediate action plan for when a disaster strikes. And this is sort of the most dramatic one that obviously I think anyone has really been involved in, especially from the infectious component. But I think for me, I had never really thought about this before until this really sort of became very clear that this was a significant problem. And so there were two things that we were sort of focused on. One was really resident safety and exposures from an actual viral standpoint. The other was how to maintain patient care during all of that time. And so the big things that we sort of immediately realized is that, especially when the stories were coming out about aerosol generating procedures and the fact that these were sort of higher risk for transmission, our concern really had to do with the fact that obviously residents often are the first line. They're the ones that are taking call. They're the ones that are being called to the emergency department and potentially being asked to do procedures in patients that we don't know whether or not they could be infected. And so we sort of very rapidly realized we needed to figure out how many residents we really needed to be in the hospital, because in a normal situation, there are a lot of residents that are actually there. So we decided to create 2 separate teams that were teams of residents that were the actual minimum number that were necessary. So that they didn't actually interact with each other. And we also limited residents going from one hospital to the other. So often we have residents cross-covering in different institutions. We stopped that. So we tried to limit the actual resident exposure from one to the other. And we also sort of made sure that rounding, for instance, for inpatients, that we limited the number of people that actually went into rounds. So we sort of created a way that only one resident would actually physically go into a patient room, and then there was a virtual way that the rest of the team could be socially distanced in the hallway. And really simple things like making sure the resident room actually gets cleaned at the end of every shift, so that we had the housekeeping actually go in and clean everything and all of the computers, assigning residents to use actually their own laptop rather than touching other workstations, so that they're sort of limiting actually what they were doing. We had chief residents who were stationed at home that sort of took all of the consults actually. So rather than we usually have a PGY3 that's sort of running a consult service. But what we did was we had residents that were not physically doing things at work because we didn't need the same number once the number of elective cases went down. They handled most of all of that over the phone and really triaged whether a patient really needed to be seen, especially if their COVID status wasn't known and there was a concern about doing something. We were able to do a lot of consults actually virtually. And so then if someone really needed to go and see the patient, then that chief resident that was home would then talk to the resident team and dispatch them to go actually help take care of that. We also pulled the residents out of all of the clinics at the beginning. And again, that was just until it was clear that they were going to cancel most clinics. We actually just removed residents from clinics at all. And then initially actually really sort of limited their exposure in cases that were single operator surgeons like sinus surgery and laryngology that were at the very beginning of this considered higher risk. And again, when we weren't really sure what the status was as far as COVID testing and how accurate the tests were. So they were still participating in head and neck cases, for instance, but we really sort of limited the actual surgical exposure. And that was sort of within the first week, were things that we sort of did very, very rapidly, again, to try to really protect the residents and think about how we were using PPE wisely for the entire team. And then after that, it's really sort of been a process of figuring out how to relax all of that. And that has been a very gradual process. And I feel like almost every week it's a reassessment of how the team structure should look, what the residents should be doing. And as we got more comfortable and as the PPE situation became much more stable, then we were able to sort of slowly allow people to participate. The biggest problem right now that I see where we are is really just that, especially for us, our clinical volume really was dramatically reduced. So the number of clinical experiences and cases over the last several weeks has obviously dropped dramatically for all of the residents. And based on how they're planning for us to restart, that's not going to change very much for a very long period of time. And so now the way that I look at it is we're in the recovery phase, and I'm sure we'll talk about that. But I think for all programs, it has been very useful to have this kind of like immediate disaster plan. And then after you kind of implement that to make sure everybody stays safe, and we were very lucky, we didn't have any residents that got sick. Then you can sort of figure out then how you recover from the fact that you drastically cut everything. I don't know if I covered everything. That was a lot of talking that I just did.
No, that's great. You covered it. And similarly for Rich being in this epicenter, and did you do the same thing where you had 2 teams, a team at home that was sort of that sort of safe out of the hospital, and the team that was in the hospital taking care of patients? And then also, how did you manage deployment? Because I imagine that was certainly necessary in New York.
So the interesting thing, we have a lot of similarities with what Stacy did, but a few differences due to the slightly different needs. So we had residents that were at several different institutions. I mean, all part of our program, all our hospitals. We have an East and a West and a public hospital. And we pulled them all back to the main hospital so that they could be part of the general pool for both redeployment and for covering the service needs. Very early on, just like Stacy described, we took them out of the clinic. We did not have them go to the clinic. We reduced the numbers that would be on service. So whereas we would usually have 6 to 8 on service at a time, depending upon which part you were looking at, we cut it down to 2, and they would alternate. So it would be a pair of a chief and a junior resident for a day or 2, and then they would alternate back and forth. So similar in respect, not completely out, but more rotation through so that they didn't get exposed to everything all the time. We saw a dramatic decrease in consults because of the decrease in non-COVID related things in the hospital. We did early on tell everybody we were only going to do fiber optic scoping or nasal endoscopy in absolute emergencies because it was recognized that that was potentially a risky procedure at that time. So we did that along with the implementation of disposable laryngoscopes or fiber optic scopes that we had implemented shortly before as well. So there were a lot of measures to try and keep everybody safe. The deployment was really a different beast altogether, if you will, because it was the entirety of the hospital, and the GME group was in charge of all the residents. And they said, well, how many residents do you actually need to run your service now? And we'll take all the rest. Thank you very much. And what we did is rotate all of the residents through. So there were 4 or 5 at a time that would staff the ICUs for 5 days. Then they would be on our service for 5 days, and then they would have a 5-day break to kind of recover both physically and emotionally over that time frame. So a little bit different. And we created a schedule amongst our own residents. We had our chief resident create a schedule across all of the residency that would allow us to populate. So rather than just giving all of the residents' names as an example to the GME pool, we would say, well, what do you want from us? We're going to staff these ICUs, so we need 4 or 5 a week. So here are the ones we're going to do. So we kind of maintained control so that we could have the appropriate pairing when they were back on otolaryngology instead of all being deployed. And part of the reason that we were asked to deploy was because of the airway skills and the critical care skills that we do have for pre-flap patients and other things. So there was a reason that we were asked to come to the ICU, and that was due to the skill set that we bring to the table. Although, you know, there was a lot of upfront education needed. So we did a lot of module learning for critical care and revisiting how to manage vents and other things of that nature. But in speaking to the residents afterwards, you know, because I've asked a few, there was a lot of anxiety initially, as we all had, not really knowing what it was going to be like, not knowing what kind of patients were going to be there. I mean, other than COVID positive, but exactly what the medical conditions would be. And pretty soon after everybody felt that they were up and running and doing it more frequently, they really were very happy that they learned these skills again, or relearned these skills, and could contribute in a very meaningful way to the care of these patients, which I thought was very heartening. And what I would have hoped, but certainly what was delivered by all the residents. So it was really a wonderful thing to see from them. Although logistically a challenge, and I think Stacy's point is well made, that we really need to take the lessons from an experience like this and across the country, regardless of how hard you were hit in this particular moment, to develop a plan that will allow you to move into these other areas and help when the hospital needs help. And it's not something that we've done formally in this way. I think in the past, we always have a disaster plan, but this is a little different than that. And it's been a real learning opportunity for all of us, and has really both created great sense of community within the family of otolaryngology, but also given us some management skills and, you know, acute management of disaster. And I think we need to learn from those and have these plans in place in the future.
Yeah, I know one of the challenges for us was the shortage of PPE, and how do you ration that? You know, how many people do you need in a room to examine a patient, and, you know, et cetera. So Jeff at Pittsburgh, how did you guys handle that? Did you, you know, how did you mitigate having a resident or a learner in that environment?
I'm glad that you mentioned that, Sonia, because it was something I wanted to bring up. So we also did implement a resident team type of model where we kept the residents segregated at individual hospitals, and even within some of the hospitals would keep some residents at home and some at the hospital and made sure that they weren't interacting, so that if one resident got sick, they wouldn't expose the rest of the program to the virus. Particularly early on, it wasn't sure what the situation with PPE was going to be, how much was going to be available, how long was this going to go on for. And so the administration of many of the hospitals and the health system in general encouraged keeping trainees out of situations where they needed to use PPE as much as possible. So we kept our trainees out of the operating room for another number of weeks, except for emergent situations. We had them out of the clinics, and we had them only seeing consults on the floor. And I want to emphasize that this was really an evolving situation. I think when we go back and look at things over the past 2 months, what we expected 2 months ago and what we've learned has really changed with time. So over the past several weeks, we've gradually increased the involvement of the trainees. They're now back in the operating rooms. They're helping us, particularly in patients that are tested and known to be COVID negative. And now there's a lot more for elective cases of COVID testing that's strongly suggested or required, and that lets us involve more trainees. We also realize that there's more availability of PPE than we initially thought there might be, and that's allowed us to involve more. We're still not having trainees involved in the care of COVID positive patients, except in very particular emergent situations, which is very different than what the situations in New York, where they were actively involved in the management of COVID positive patients. One other thing I want to mention is that this has really brought otolaryngology residency programs together in many ways. There's been interaction amongst the program directors, amongst the department chairmen, amongst other leaders in departments to learn from each other and talk about situations around the country to see how people are managing it. And because nobody really had experience in this type of situation before, I think those interactions, and a lot of them were one-on-one or with Zoom meetings or other types of conference calls that happened throughout this 2-month period, have been really critical for us all to learn together about how to best manage the COVID situation.
And Carla, I really want to hear from you and sort of the resident perspective in this. You know, the residents are often been, pushed to the front lines to take care of our COVID patients and sort of, I guess, the most vulnerable healthcare providers, if you will. I hope some of our listeners and you guys have listened to one of the podcasts, The Band of Residents, where it highlights 2 of your colleagues at Mount Sinai, New York. And I thought it was a really moving and inspiring story of how they rose to the occasion and they contributed to those frontline efforts. And obviously the experience for the residents across the country has been very different, depending on whether you're an epicenter or not. And it's all been affected in a different way. But from your perspective, what are the key issues that our residents are dealing with?
I think there's always a fear of not knowing whether a patient is COVID positive or not when you get a consult. Initially when, COVID was surfacing in like March, our faculty put together guidelines about how to manage certain consults. There was a reduction in the number of consults that were not urgent that were placed. And it was just helpful to have guidelines on, what to do if you have an epistaxis and, you don't want to start like aerosolizing afrin and lidocaine. So all those things we had guidance on. In terms of the biggest issue with residents right now, I think there's a big concern about case numbers. So elective cases were canceled, clinics were canceled and then moved to telehealth, which residents usually aren't involved with. And now that we are reopening, it's just unclear how this will affect our case numbers, affect our competency in cases, how it will affect just, how many patients want surgery in the future. There's just so many unknowns.
Yeah, and those are great points. And Stacy, I'll turn to you as program director. Are you getting any guidelines from national regulatory bodies and some of the societies and how this next year is going to look and what we're going to do in terms of their clinical experience as well as their operative cases?
So, I mean, I think I will say I do think that it has been wonderful to have some good guidance from especially the Board of Otolaryngology head and neck surgery, and sort of really, I think, reassuring trainees, especially the current chief residents that are going to be graduating this year, that when it comes to sort of assessing competency, that it really is up to the program and the training director, which for me, that's been very reassuring. I think for trainees, that's been very reassuring. In addition to the fact that there's obviously been a need for increasing flexibility, for instance, for the PGY1s and what rotations they're going to have actually experienced this year, because many were reassigned. Some of our residents were reassigned during the PGY1 year if they happen to be on general surgery or neurosurgery, just because of the nature of everything that was happening. And I think that given the fact that institutions were able to declare themselves sort of significantly affected by the pandemic through the hospital and through the DIO, I think the ACGME has been very clear that things will look different and case logs are going to look different. And I think that that on a national level, I think there's been a lot of reassurance that we know that this will not look the same as it has in the past. For me, on a personal level, I think everyone needs to realize, for instance, that fellows that are starting in July for this year, or residents that are graduating and are planning to go into practice right after finishing, their comfort level or sort of the way that they feel about it might be slightly different than it would be in a normal situation. And I think what we can really do is provide reassurance in those situations, and also as much mentorship as we can for people that really want it. And so understanding that we're all at a high level of anxiety, everything looks different, everyone's practice, we know that things are going to be different, and we're all trying to figure out how to cope with that. So I think the more that we reassure everyone, the same way that I'm reassuring my high school freshman daughter about the fact that obviously school for her looks very different and next year is going to be very different, and none of us really know what to expect. I do think that we, for a long time, have really sort of tried to push towards the idea of competency-based education rather than numbers. And I think now is really the time to embrace that and to realize that a false number of having done 40 ethmoidectomies has literally no bearing on whether or not you're actually a good and safe sinus surgeon. And I think we need to be very proactive about explaining that to our trainees and telling them how to do that. We need to be more explicit in our teaching now. And I think we're going to have to create other educational opportunities, whether or not that means having multiple residents in the same case if the case numbers are low, splitting up what different residents are able to do during those cases, and really being much more prescriptive about teaching. And so I think it's up to us to really make sure that we figure out what opportunities are actually available, but also letting our trainees know, like, they are going to be fine. I'm not worried about that. They are absolutely going to be fine. It's just going to be slightly different. So rotations might look a little bit different. The way that we're teaching in the operating room might look a little different. Consults might look different for everyone forever. And I might not ever see another patient in clinic. I might just do only telehealth and only do endoscopy clinics, but I'm going to figure out a way to involve the residents in that. It's just that we all are adapting and changing. And I think we just need to make sure to remember to include the residents in that and reassure them that we're going to figure out a way to do it together. It's just going to, and I think that we can be creative. Like, it's an opportunity to make things better. There are a lot of things that are clearly better. Having a national curriculum, Sonia, you and I have talked about, wanting to do that for a really long time. Now things are done online. The fact that there are just so many, I do think that it's allowed us to really get out of the box of our standard thinking, because we've had more time and freedom to do that. And I hope we're going to continue to embrace that going forward.
And Jeff, you mentioned how the specialty has come together. Can you speak a little bit to what has happened in terms of didactics? So the traditional didactics that we're all used to and the traditional ground rounds, how has that evolved? And also, what has the Academy's response been?
Absolutely, Sonia. So as I mentioned before, the COVID-19 crisis has really been a disruptive force that had required us to lead to to develop a lot of innovative ideas, not just for how to practice medicine and take care of patients, but also for how to educate practicing otolaryngologists, and also how to educate residents. For residents, there's less time in the operating room, there's less time in the clinic, and there's also less time for us all going to national meetings. There's been no national meetings in the spring of 2020, which has been a major change for our field. So some of the things that have happened in general that have been very sort of enlightening and gratifying, there's been a few, I think 2 or 3 different national lecture series that have been developed, not by the Academy, but by individuals or Opto that you're involved with to educate residents, to provide a didactic curriculum. And the nice thing about this is it lets residents really learn about a variety of topics from famous people all over the country that are really experts in the field. I think this is something that's probably going to be enduring well beyond the time of the COVID-19 crisis and situation. So that's been really interesting. I also want to mention some of the things that the Academy has done for resident education and professional development during this time. One thing that I think is really very nice for residents is that we elected to make the entire home study course plus catalog free for all residents in the country through August 31st. And you and I chatted about this, and I was so glad that Dr. Denany, the EVP of the Academy, supported it. So for the next several months, residents have access to all of the Home Study Plus things for free. There's been tremendous positive feedback about that. There's 61 training programs that have been involved, taking advantage of that, and 773 residents right now are using our products. And I, from program directors and also from some residents around the country, have heard very positive feedback about that idea. The Academy has also done a number of other things to help with education during this time. One is this COVID-19 podcast series, for which there's already 16 modules out, and this is the 17th. And they cover a variety of topics that are on all of our minds right now, from patient safety to telemedicine to personal experiences with COVID-19. For example, the residents at Mount Sinai that independently created their own ICU, which was really an interesting story to hear about. We've also worked with our practice management education committee to develop an online course on telemedicine. It was developed in 2 to 3 weeks. It's probably the fastest online course that's ever been developed and published. So that was really neat to see that happen. And I think we're all stepping back here to see this. This is a terrible situation that we've been in for the past few months, and it's created a tremendous number of challenges for patient care and also education. But it's also made us rethink things, and I think it's going to lead to some significant enduring paradigm shifts for where education goes in the future.
Yeah, I agree. And Carla, from your, what do you hear from the residents? I know my residents have really liked some of these lecture series, the consortia. Can you give us some feedback on from the resident perspective?
Yes, I think first and foremost, we have really appreciated all the constant communication from our department chairs and program directors. So I know this time there's just been so many changes. There's been tons of emails like every day from the hospital about COVID. But through it all, like our program director at my program, and I know program directors across the country have just constantly been checking in with all the residents, making sure that everyone's okay, being available to talk through, how residents are doing. And so I think we really appreciate that. And I just wanted to make sure that I said that because it has meant a lot to just have our program directors really just always be available and be very reassuring. So thank you to all the program directors and department chairs. In terms of resources, so our program directors have given us many opportunities for learning. We've had the USC lecture series, Kentucky's consortium, the Corona Initiative, and the Great Lakes Initiative. Academy U, like Dr. Simons mentioned, has been offered and made available to residents. We've really enjoyed the lecture series. I think it's fantastic to access them if you can make it at the time that they're being shown live. And if you can't, you can easily watch a past video, which has been really helpful. It's been really cool to see, these big names in the field, give us lectures. So it's been great. We've really appreciated all the opportunities for learning.
And so I want to transition a little bit and to look ahead. We touched on it to some degree, but I'd love to hear all of your perspectives on how you think training really is going to be different. As physicians, we sort of thrive on those personal relationships and contact with our patients. So how are we going to train otolaryngologists in the future within the confines of the social distancing? Again, we've talked about how this paradigm is going to change. And Rich, I'd love to hear from a chair, your perspectives on this.
Well, I think we all hope that there'll be some return to what used to be called normal. So we're all holding some hope for that. But I agree with Stacy. This has really provided everyone an opportunity to really refocus and to shift from numbers-based training to competency-based training. And I think that that will also extend into the clinics and not simply into the ORs where it's easiest to measure. We're going to have to find new ways to measure an effective experience with a resident and a physician and a patient, things that we haven't thought about before. How do we assess that? Because that's been an equally critical component of the practice of medicine for millennia. And it's not something that we've been really focused on measuring other than kind of the gestalt of what it's like when you're in the office. What is important also, I believe, is the need to engage the residents in the telehealth. Telehealth is going to be something that's going to be with us forever now, whether it be video or telephone. So what we've been doing is having the residents work with us in the office when we're doing our telehealth session, both the video and the telephone ones, just so that they can see how it works and how we can incorporate that into the general practice. We've also recently created a telehealth clinic for the residents where they follow the patients that they consulted on in the hospital. So the patients who've been discharged from the hospital, they'll actually do the telehealth with in the office and have a faculty mentor for that. So using these new technologies to extend the educational experience and really focusing on some of the things that may have been de-emphasized in the area or in the era of procedures rather, which is, you know, the interpersonal skills. And while it is great to see somebody in person, and there is a definite component of that that's important, you can also do very good medicine in a telehealth call if you're familiar with kind of how to ask patients questions, how to really refocus on the interview skills that we tend to develop further along in practice. We're going to have to shift that forward. So many changes to come, and it's exciting because this has eliminated a lot of barriers to change. And everybody who's on this call today and on this podcast has been interested in change. And it's not been easy to get it to happen. And this will facilitate change and allow us to evolve and really extend our educational experiences into more adult-based learning techniques than some of the things which may not have been as effective, but have been easiest to kind of redo all the time. So for me, I think there's a lot of excitement about this. I think many people in education find this to be exciting. We don't find Zoom to be exciting all the time, but it is a component of it. But it allows us, as Stacy and Jeff have both said, to really think about new ways to do things. We have a little bit of free time to do that with now, and we're also being forced to change what we do, to reevaluate what risk it is for everybody. There'll be an increased use of patient-based simulation, I believe, things of that nature. So the shift to competency from numbers, I think, is long overdue, and the hand will be forced in the current crisis, and I think that's actually quite a good thing.
Should only be a lot of challenges, but opportunities as well. So I agree. Stacy, as we sort of start ending here, as a program director, I'm thinking about the future of onboarding and the recruitment process in this COVID era. Do you have any thoughts on that?
Yeah, I just had a Zoom meeting with all of my residents this morning about this. And obviously, I'm still distraught over having to do graduation differently this year. I will just say that I literally am waking up having nightmares every morning when I wake up, worrying about how I'm going to make that feel special for our chiefs this year. Because I know for all of them, they've been working so hard for the last 5 years, and at least for our program, it is definitely sort of it's such a celebration, and not sort of having that personal touch is really going to be difficult. And so trying to figure out how to translate that into some kind of socially distanced virtual component. I'm like so focused on that, but then I realized I really need to start thinking about the fact that we're not going to have any away rotating students this year. We're going to be doing virtual interviews. Everything is going to be drastically different. And for me at least, what I always do in these situations is ask the residents for solutions, because they are always the ones that are extremely creative at solving these problems. So we're doing a lot of brainstorming today to try to figure out, how to really let people who are not actually spending time at our institution know who we are, know who our residents are, and feel comfortable with that, just because I know from an applicant standpoint, this year is going to be tough just because they're going to be making decisions without actually personally meeting people. And fortunately, all of this, everything that we're doing right now is a little bit, we're adjusting to that. So we're all adjusting to the fact that everything is being done virtually. And at least for some of our residents that are going through fellowship interviews right now virtually, I do think we'll be able to do it. It's just really an adjustment, and it will definitely be very different. So I am open to any suggestions. So if anyone knows how to make graduation seem like the real thing, and how to make interviews and away sub-Is work virtually, I'm all for it. I think the more that we have, I think the other thing I was going to mention is just the fact that we have had such an open line of communication, partly through the Academy with ENT Connect and all of the other sort of online forums. It's been so wonderful, really, I think, for idea sharing. And I think that is another thing that has really become very apparent, is that we do get great ideas from sort of talking to people across the country, because everyone is thinking about it a little differently. And I'm waiting to hear who figures out how to do this part of it well.
I agree. The residents definitely have their fingers on the pulse, and then they do guide us moving forward. And so, Carla, any closing thoughts from you and the residents on what you would want from the programs and program directors moving forward?
I think just what we're getting right now, all the communication and knowing that hopefully we've been through the worst and we've shown that we're adaptable, that we're all willing to just take it for the team, be a team, step up if we need to be deployed, etc., and ready to see what this new, next few months look like.
And Jeff, I'm going to turn to you if you could tell us a little bit about what's on the horizon in the Academy in terms of education.
Absolutely. As Richard mentioned, I think everybody on this phone call is interested in change. And during my time as the chair-elect, and now my first several months as coordinator-elect, and for several months as coordinator for education, there's been a number of things that I've wanted to do, and it's become evident that virtual platforms for education were going to become more important. This unexpected turn of events over the past couple months has really pushed everything forward and broken down a lot of the barriers that we've had to change. For example, it's been clear that people are more and more interested in online education and virtual opportunities. There's been a 600% surge in enrollments, for example, in online courses from Academy U over the past 2 months. 600%, it's unbelievable. There's 800 new learners that are using our online platforms over the past 2 months. These are really incredible numbers that suggest that people are looking for new ways to learn. The biggest thing that the Academy is doing for education, and we've talked about it, and I think many people have started to hear about it, is a new educational platform that's going to be a replacement for the home study course. It's called FLEX, or Focused Lifelong Education Experience. And FLEX is really going to be a multi-modality educational platform to let users from the level of medical students and residents through senior physicians obtain their education when, where, and how they want it. It's going to be launched in September, and we're already actively working on developing the programs that are involved with it. Stacy is the chair of the Rhinology Education Committee and is going to have the first of the modules that will come out in September. You'll hear more about that. But there's going to be parts that involve articles with expert summaries. There'll be podcasts and live webinars that allow people to be interactive with experts. There's going to be recorded surgical video procedures, guided discussion topics, and a variety of other. There'll be a case of the week for each module to allow interactive educational experiences that are entertaining and engaging. And there'll be 8 modules per year covering all the main subspecialties. And so each subspecialty will have 1 module each year. And I think it's really going to be a great way for people to learn in an interactive and in entertaining, engaging way. And there'll also be opportunity to get immediate feedback from some of the different types of educational experiences that are part of FLEX. You'll be hearing more about that as we move forward over the next few months. And I hope that you all take a look at it and consider signing up and enrolling in the FLEX experience.
That's fantastic. I'm looking forward to it, and I'm sure the residents and program directors and our practicing physicians will also very much appreciate all those efforts.
The other thing I want to mention, thanks for bringing that up, is for residents, when they enroll in Flex, they're also going to have access to the annual meeting webcast from the previous year, and all enrollees in the Flex opportunity, in the Flex experience, are going to have access to the Academy U library. So not just the monthly modules, but to the over 200 or 250 educational activities that are available in Academy U. Residents, as part of Flex, will also have access to the Academy Q question bank. So there's going to be really a lot of things that come as part of the Flex educational platform.
Terrific. And Rich and Stacy, any closing thoughts?
I'll let Stacy start.
I will just echo what has already been said, which is that I am really proud of all of our trainees during all of this, and just how much grit and grace they have shown through being thrown into very uncertain times, and really proving to all of us how wonderful they all are. I really just, I think that's what I have taken the most from this, is I am just, I think we're all blessed with having really wonderful trainees. We're really lucky as a specialty.
I would just echo everything that's been said. It's really been a difficult time, but also a wonderful time to see people getting together that haven't really done that in a meaningful way across the country, and it's really united the specialty with respect to education and pretty much everything that we do, resident focused and patient focused. And it's nice to see that. It's unfortunate that it took such a pandemic to bring that about, but the ability of us all to get together to share the information rapidly, to come up with mutual solutions and really work towards the betterment of the specialty and towards educating our residents, I think is a phenomenal component that's going to come from a very difficult and trying time.
I could talk about this topic for hours. There's so many nuances, and uncertainty is daunting, but ultimately medical education will be forever changed. And I think there's tremendous opportunity here for innovation. I want to thank you all for joining us for this podcast. I want to thank our panelists for their time, their insightful comments, and the great discussion. And I'd like to remind our listeners to continue to visit the COVID-19 resource page at entnet.org for all of the latest information during the pandemic, and continue to share information and inspiration at ENT Connect as we get through this difficult time together. Now, as always, we are one. Thank you.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.